Welcome to your concise gastrointestinal review. We're hitting disorders and meds with a laser focus on exactly what you'll see on the RN exam. Brought to you by NCLEXReviewPro.
In 5 sections, we have covered the must-know gastrointestinal disorders and essential pharmacology.
All right, let's get right into it. Today, we're taking a deep dive into the gastrointestinal system. And look, this isn't going to be some dry textbook chapter. We're cutting right to the chase, giving you the high-yield info you absolutely need for your exams and, more importantly, for your clinical practice. I mean, just think about that for a second. The very system that's supposed to give you life can actually start turning on itself. It's a pretty wild concept, right? And honestly, that core conflict is at the heart of so many of the GI problems we see every day. So we're going to follow the path food takes all the way down. We'll explore what happens when things get inflamed or, completely blocked. And then we'll get into the fun part, our arsenal of medications we use to fight back and get things under control. But first things first. Before we can really tackle the problems, we got to know what normal looks like. So let's start with a quick tour of the GI tract and how it's all supposed to work when things are running smoothly. Think of this as our roadmap for today. The alimentary canal, really, it's just one long, muscular tube that snakes its way all the way from top to bottom. We're going to follow that entire path. The big thing to get here is that every part of this tube has a very specific job. It all kicks off in the mouth. Then the esophagus sends it down to the stomach, which churns everything into this stuff called chyme. After that, the small intestine is where the real magic happens. That's where we absorb all our nutrients. And finally, the large intestine just pulls out the leftover water and electrolytes. All right, so we've got our map. We know the lay of the land. Now let's meet our first villain, stomach acid. Look, acid is good, we need it. But when it goes rogue, gets out of control, or ends up in places it shouldn't be, that's when all the trouble starts, especially in the upper GI tract. Now, this is super important. GERD, gastritis, peptic ulcers, they sound different, but you know what? They're all basically cousins. The root cause for all of them is acid. The only real difference is where the damage is happening. With GERD, acid is splashing back up, burning the esophagus. With gastritis, the entire stomach lining is angry and inflamed. And a peptic ulcer? Whoa. That's when the acid has literally burned a hole right through the lining. It's all about location, location, location.
Check this out. The key to telling the difference between gastric and duodenal ulcers is all about the pain and when it happens. Think of it like this. With a G gastric ulcer, food makes the pain greater. But with a D duodenal ulcer, food makes the pain decrease. You will see this on your exam, so lock this one in.
A question about GERD, I can almost guarantee it's going to be about patient teaching. It is everything. We're talking lifestyle changes, right? Stay away from the triggers. Coffee, fatty foods, you know the drill. Don't lie down right after you eat. Let gravity be your friend. Prop up the head of your bed. These seem like small things, but trust me, they make a world of difference. Okay, let's keep moving down the tract. As we go lower, the problems change. We're not so worried about acid anymore. Now we're dealing with different challenges, like actual physical blockages and some really nasty chronic inflammation. So when we talk about intestinal obstructions, you've got to know there are 2 main types. Is it mechanical, meaning something is literally blocking the path, like a tumor, or is it non-mechanical, what we call a paralytic ileus? That's where the bowel itself has just stopped working. It's paralyzed. And knowing which one it is, that changes everything about how we treat the patient.
Let's say you suspect a bowel obstruction. Maybe you hear those classic high-pitched, tinkling bowel sounds. What do you do first? Here are your priorities, right in order. Number 1, make the patient NPO, nothing by mouth. Then you'll likely insert an NG tube for decompression. It's all about resting that bowel and preventing things from getting worse.
Differentiating between an upper and a lower GI bleed is a really critical assessment skill. So if you see coffee ground vomit or black tarry stools, that's called melena, you should be thinking upper GI bleed. On the other hand, bright red blood in the stool, that points to a lower GI bleed. Knowing the difference helps you figure out where the problem is. Difference is absolutely key.
So when you see a question describing these signs, especially that classic right lower quadrant pain at McBurney's point, your nursing brain needs to light up. This is not just a tummy ache. It's a potential time bomb. Your number 1 job is to prevent a rupture. And speaking of rupture, this is a massive, massive safety point. You never apply heat. You never give laxatives. You never give enemas. Why? Because anything that increases pressure or movement in that area could make the appendix burst. That leads to peritonitis, a life-threatening infection.
All right, enough of the problems. Let's talk about the solutions. It's time to take a tour of the GI pharmacy and check out the arsenal of drugs we use to fight back. First up, we've got the first responders, antacids, your Tums, your Rolaids. These are for when you need help right now. A patient has sudden heartburn, boom, antacids jump in, neutralize the acid immediately, and give super fast relief. But, and here's the catch, it doesn't last very long. It's a quick fix.
And here's a little memory trick to keep the main types straight. Just think SCAM. S is for sodium bicarbonate, C is for calcium carbonate, that's your Tums, A is for aluminum hydroxide, and M is for magnesium hydroxide. SCAM. Easy, right?
Okay, listen up. If you take away only one thing about antacids, let it be this. Antacids are anti-mixing with other medications. They totally mess with how other drugs are absorbed, so you never give them at the same time. It's always 1 hour before or 1 hour after any other meds. This is a huge safety point. So moving on from the quick fixes, we have the H2 blockers. You'll spot these because they all end in titidine. These guys are different. They don't just mop up the acid that's already there. They go to the source and actually turn down the volume of acid production, so they give you longer, more preventative relief. And then we bring out the big guns, the proton pump inhibitors, or PPIs. All their names end in prazole, like omeprazole. These are, hands down, the most powerful acid blockers we've got. In the hospital? Oh, you'll see these everywhere. We use them for something called stress ulcer prophylaxis, basically to stop super stressed out patients from getting ulcers in the first place. A great way to remember the key points for PPIs is with the 3 Ps. It's super helpful. First P, they prevent holes. That's the stress ulcer prophylaxis we just talked about. Second P, they can lead to porous bones. If a patient is on them for a long time, we have to watch out for osteoporosis. And the third P, possible C. diff. Why? Well, if you suppress all that stomach acid, you're also taking away a key defense against nasty bacteria. So prevents holes, porous bones, possible C. diff. Okay, this slide just ties it all together perfectly. Think of it like this. Antacids, they're your rescue inhaler, your albuterol. You use them for an acute attack for fast relief. H2 blockers, that's more like your daily controller medication. And PPIs, they're the super long-acting stuff, like Lantus insulin, giving you 24-hour coverage. Rescue, controller, long-acting. It's the perfect way to think about it.
Now, for chronic pancreatitis, pancrealipase is the key medication. It's an enzyme that helps the body digest food. And the most important teaching point, and you guessed it, a common test question, is that it has to be taken with food. Not before, not after, but with every single meal and snack.
So we've been on quite a journey, right? We've covered the path, the problems, and the pharmacy. Now let's get really practical. Let's talk about the key things you need to know when you're actually taking care of these patients. Let's talk ostomy care. This is so important. That little stoma, it needs to be nice and beefy red or pink and moist. If you see one that's pale or dusky or blue, that is an emergency. It means it's not getting enough blood and you have to report it immediately. And when you're cutting the wafer, be precise. No more than 1/8 of an inch larger than the stoma. Any bigger, and you're going to destroy the skin around it. And here's a rule that you cannot ever break. If that ostomy bag is leaking, you don't just tape it down. You don't try to patch it. The entire thing has to be changed, right then and there. Especially with an ileostomy, the stuff coming out is loaded with digestive enzymes that will literally eat the skin. No shortcuts. So let's wrap this all up with one final question for you. Your patient is complaining of sudden, really bad heartburn right now. Are you going to reach for a PPI like omeprazole, or are you going to grab the Tums? Think about it. The answer really gets to the heart of everything we've talked about today. Fast relief versus long-term control.
Or nursing priorities that kind of tie all of this together. Let's zoom out for a second. You know, at the end of the day, no matter what specific GI problem your patient has, it often comes back to these 4 things. You are always on the lookout for a rigid, board-like abdomen. That screams peritonitis, which is a medical emergency. You're always managing fluids and electrolytes, and you are constantly watching for any signs of bleeding or shock. These are your core GI nursing responsibilities. So let's end with this one final checkpoint to pull it all together. You've got a post-op patient with a rigid, board-like abdomen, a fever, and tachycardia. What is your priority action? Thinking through this scenario, knowing what you do first, that is the kind of clinical judgment that's going to make you a fantastic nurse and help you crush the NCLEX. You've totally got this.
All right, welcome. Today, we're going to break down two topics that trip up so many people on the NCLEX: irritable bowel syndrome and inflammatory bowel disease. If you can get these straight, you're going to feel so much more confident on exam day. Okay, let's just dive right in, because honestly, getting this one single concept down is the key. It's the foundation that unlocks the right answers for dozens of potential questions. Everything else we talk about builds on this.
So here's our game plan. We're going to hit the core difference between IBS and IBD, then zoom in on Crohn's versus UC. We've got a killer comparison chart for you. Then we'll cover management, the big red flags, and wrap it all up with a rapid review to make sure it all sticks. Let's do it.
All right, first up, this is the single most important distinction you need to burn into your brain for the NCLEX: functional versus structural.
Think of it this way, okay? IBS is a functional disorder. It's like a software problem. The gut's hardware looks totally fine on a colonoscopy, but the programming is off. It just doesn't work right. Now, IBD is structural. This is a hardware problem. There is real, visible, physical damage, inflammation, ulcers, all caused by the body's own immune system going haywire.
So here's the bottom line. If you get an NCLEX question and the patient has any of these big red flag symptoms, especially things like bloody stool, a fever, or they're losing a bunch of weight, you can immediately rule out IBS. These signs scream inflammation and damage, which means you're dealing with IBD.
So, now that we've set IBS aside, let's zoom in on IBD. We know it means inflammation and actual damage, but now we need to figure out the two different ways that damage shows up: Crohn's disease versus ulcerative colitis.
First up, we've got Crohn's disease. To really nail this for the exam, you just have to remember three things: where it shows up, how deep it goes, and the classic signs that result from that.
Crohn's is like this unpredictable wanderer. It can pop up anywhere from the gum to the bum, and it creates these skip lesions, which are patches of disease next to healthy tissue, giving it that classic cobblestone look. But the most critical word here is transmural. It means the inflammation goes through the entire thickness of the bowel wall, and that deep damage leads to one of its most serious and high-yield complications: a fistula. Yeah, because that inflammation is so deep it can literally burrow a tunnel right through the intestinal wall, connecting it to other organs like the bladder or even out to the skin. This is a direct result of that full-thickness inflammation, and it's a huge way to tell it apart from ulcerative colitis.
Okay, so let's flip the coin and look at ulcerative colitis, or UC. It has a totally different and honestly a much more predictable pattern of attack. See? Unlike Crohn's, UC is a total homebody. It stays put in the colon and the rectum, and the inflammation isn't patchy. It's one continuous sheet that starts at the rectum and works its way up. Also notice it's superficial. It only hits the inner layers. But don't let that word fool you, because that continuous inflammation destroys the lining that absorbs water. The main symptom can be really dramatic and really dangerous.
You heard that right. We are talking 10 to 20 bloody liquid stools in a single day. I mean, can you even imagine? This is so much more than uncomfortable. It's a full-blown crisis. Your patient is at massive risk for severe dehydration, electrolyte imbalances like low potassium, anemia from all that blood loss, and a straight-up medical emergency.
And that emergency is called toxic megacolon. You have to remember this term. The inflammation gets so bad that the colon just becomes paralyzed and swells up like a giant toxic balloon. It can rupture. This is the most dangerous complication of UC, and it needs immediate aggressive action.
Okay, take a deep breath. This slide right here pulls it all together. If you're going to screenshot one thing today, this is it. This is your high-yield exam day cheat sheet.
Seriously, pause here and just absorb this. Look how clear the no's are for IBS. Inflammation? Nope. Bloody stool? Nope. Weight loss? Nope. Then see how fistulas are a yes only for Crohn's. That's because of its transmural depth. And check out that last row. That's a huge clinical point. You can cure UC by removing the colon, but because Crohn's can be anywhere, surgery is never a cure.
So we know the what. Now it's time for the what do we do. This is where all that knowledge turns into action. This is the nursing part.
When a patient is in a flare-up, our goals are simple. Calm that bowel down, keep the patient stable, and watch for any signs of a crisis. And pay close attention to that diet, low fiber. Now the NCLEX loves this because it's counterintuitive. Normally, fiber is good for you, right? But during a flare, fiber is like rubbing sandpaper on a sunburn. We want to reduce that irritation as much as possible.
Now for meds. With almost all of these, but especially the big guns like immunomodulators and biologics, I want one word flashing in your mind: infection. That is your #1 priority. We are deliberately suppressing the patient's immune system to stop it from attacking the gut. That makes them incredibly vulnerable. A low-grade fever that you might ignore in another patient is a massive red flag here.
And that brings us to the highest level of nursing judgment. This is about spotting a disaster before it happens. It's about recognizing when your patient is about to go off a cliff.
If you walk into your patient's room and you see this specific combination of symptoms, a fever, a tight, swollen belly, a racing heart, and dropping blood pressure, sirens should be going off in your head. This is not a wait-and-see moment.
Right. Your job is to connect those dots and think, oh my gosh, this could be toxic megacolon, or they could have a hole in their bowel. You need to recognize the pattern, understand the danger, and get help immediately. This is the stuff that saves lives.
Okay, let's do a final super quick rapid review. We're going to lock these key differentiators into your brain so you can't forget them.
Remember the patterns. Crohn's, scattered cobblestones that can wander anywhere. Ulcerative colitis, one big continuous sheet of inflammation that stays put in the colon.
And what are their signature complications? For Crohn's, that deep inflammation leads to fistulas. For UC, that superficial but widespread inflammation leads to that awful bloody diarrhea and the huge risk of toxic megacolon. At the end of the day, this isn't just about passing a test. It's about building your clinical judgment so you can provide amazing, compassionate, and life-saving care to real people who are dealing with these tough conditions every single day of their lives. And that's the real reason this matters.
All right, let's dive into two of the absolute biggest topics you'll see on the NCLEX, hepatitis and cirrhosis. Now, to really make this stuff stick, I want you to think of the liver as this incredibly busy, multitasking factory. We're going to walk through exactly what happens when this factory gets attacked, when it starts to fail, and most importantly, what your priority nursing actions are every step of the way. So here's our game plan. First, we'll get to know the factory's most critical jobs. Then, we'll look at the initial attack. That's hepatitis. After that, we'll see how that can lead to a total factory shutdown, which is cirrhosis. We'll cover how we manage the dangerous fallout, and we'll wrap up with the absolute must-know NCLEX red flags and your top priorities. Okay, let's head inside the factory. To really understand what goes wrong with the liver, you have to master its 3 main departments. I promise you, every single NCLEX question about liver failure comes back to a problem in one of these 3 areas. First up is the production department. Just think of your ABCs. It makes albumin, which is like a sponge that keeps fluid inside our blood vessels. B is for bile, which helps us digest fats. And C is for clotting factors, which, we absolutely need to stop bleeding. Next is detoxification. This is the waste treatment plant. It filters all the junk out of our blood, and this is huge, it clears out toxic ammonia. And finally, you've got storage and metabolism. This department manages our energy supply, turning extra glucose into glycogen and stocking up on essential vitamins. If any one of these fails, the whole system is in trouble. So what happens when this perfectly good factory gets attacked? Well, that brings us to hepatitis. Think of it as an all-out inflammatory assault that just grinds every single one of those factory operations to a halt. Really, at its core, hepatitis is just that, inflammation of the liver. Hepa means liver and itis means inflammation. When the liver cells, our little factory workers, get inflamed and injured, they just can't do their jobs. This causes a backup of waste products like bilirubin, which leads to jaundice, and the damaged cells leak enzymes like AST and ALT into the blood. That's why those labs shoot up. For the NCLEX, you absolutely have to know these transmission routes. The mnemonic is super simple. Vowels come from the bowels. So hepatitis A and E are fecal-oral transmission. Think contaminated food, dirty water. The others, hepatitis B, C, and D, are spread through body fluids. And here's a key point. Only B, C, and D can become chronic, which is what can eventually lead to cirrhosis and cancer. Also, pay attention to which ones have a vaccine. That's a huge patient teaching point. And this slide right here, this is pure NCLEX gold. These are the exact triggers you will see in test questions. If a question mentions a client ate raw oysters or traveled somewhere with poor sanitation, your brain needs to immediately scream hepatitis A. If it mentions IV drug use or a blood transfusion from before 1992, you gotta be thinking hepatitis B or C. These are the classic cues. Don't miss them. Now, what if that inflammation from chronic hepatitis just keeps going year after year? Well, the factory doesn't just slow down. It starts a catastrophic shutdown. and that process is called cirrhosis. The absolute best way to remember cirrhosis is think sclerosis. It's that simple. Years and years of damage have replaced the soft, working liver tissue with hard, useless scar tissue. This scar tissue doesn't do anything. It doesn't produce, it doesn't detox, it doesn't store. It just sits there like a big roadblock, physically obstructing the flow of blood through the liver. So, the big question for your patient's safety is this. What happens when the factory's intricate, vital machinery is basically replaced with concrete? Well, as you can imagine, everything comes to a screeching halt, and the consequences throughout the entire body are severe. The very first and biggest consequence is something called portal hypertension. Think of it like this. All the blood from your digestive system is trying to get through the liver to be filtered, but it hits that wall of scar tissue. It's a massive traffic jam. The pressure has to go somewhere, so it backs up into the main portal vein. This backup floods the spleen, the stomach, and, most dangerously, the esophagus. And that backup leads to two life-threatening problems. First, the floors flood. Remember how the liver makes albumin, that fluid sponge? Well, now there's no albumin to hold fluid in the vessels. And you've got this intense back pressure pushing fluid out. All that fluid leaks into the abdomen, causing ascites. Second, the pipes burst. The high pressure inflates the tiny, fragile veins in the esophagus, creating these swollen vessels called varices. They can rupture and cause a massive catastrophic bleed. And don't forget, the factory isn't making clotting factors anymore, so that bleeding is not going to stop on its own. This is so critical to remember for the NCLEX. Early on, the signs of cirrhosis are really vague. Things like fatigue, maybe some weight loss, a little nausea. The dramatic, classic signs we all think of, like jaundice, a huge fluid-filled belly from ascites, and confusion, those don't show up until the factory is already in total failure. Okay, let's look at the labs because they really tell the story of the factory shutting down. The rule here is actually pretty simple. Everything that shows damage or waste products goes up. So your liver enzymes, AST and ALT, go up. Bilirubin and ammonia, those waste products go up. And your clotting times like PT and INR go up because you're not making clotting factors. On the flip side, everything the liver is supposed to produce goes down. That's mainly albumin and platelets. And platelets also drop because they get trapped in that big congested spleen. So with that detoxification department completely shut down, toxic waste is just building up and circulating through the body. This leads to the most dangerous brain complication there is, hepatic encephalopathy. Let's really focus on your priority nursing actions for managing this. The number one villain, the main culprit here, is ammonia. It's a natural waste product we all make from digesting protein. A healthy liver has no problem converting it into harmless urea, which the kidneys just pee out. But in cirrhosis with the factory down, this neurotoxin just builds and builds in the blood. It crosses into the brain, and it causes severe confusion and brain dysfunction. So what's the most crucial takeaway for the NCLEX? You have to be able to spot the earliest sign of this toxic brain state. It's called asterixis. You ask the patient to hold their arms out and flex their wrists back, like they're trying to stop traffic. What you'll see is this involuntary, jerky flapping of the hands. This is not a late sign. It is an early warning that ammonia levels are getting dangerously high. It's a priority finding, and you need to let the provider know right away. And this decline in mental status, it happens in predictable stages. It starts out really subtle. Maybe they're just a little forgetful, or their sleep schedule gets flipped. They're up all night and sleepy all day. Then comes stage 2 with lethargy and that classic asterixis. If we don't treat it, it can progress to stage 3, where they're stuporous and severely confused. And finally, stage 4 is a coma. Your job as the nurse is to catch it in stage 1 or 2 before it gets that bad. So what do we do about it? We've got 4 main tools. Number 1, our go-to medication is lactulose. Its entire job is to lower ammonia. It works by trapping ammonia in the gut and then causing diarrhea to get it out of the body. So the therapeutic goal isn't just giving the medicine, it's seeing 2 to 3 soft stools a day and an improvement in their mental status. We might also use an antibiotic called rifaximin to kill off some of the gut bacteria that produce ammonia. And of course, safety is absolutely paramount. These patients are confused, they're a massive fall risk, and we have to avoid sedatives. Finally, in an acute crisis, we might temporarily restrict their protein intake. All right, let's get into the highest stakes section here, recognizing and responding to emergencies. These are the NCLEX red flag scenarios that can harm your patient in minutes if you don't do the right thing first. Okay, imagine this. Your cirrhosis patient suddenly starts vomiting bright red blood. This means those esophageal varices have ruptured. It's a massive hemorrhage. Your #1 priority before anything else is not blood pressure, it's not calling the doctor, it's airway. Turn them on their side immediately to prevent them from aspirating blood. Then get IV access established for fluids and blood. And here's a huge NCLEX safety point. Do not blindly insert an NG tube. You could puncture another varix and make the bleeding 100 times worse. Here's another classic NCLEX trap. You've just helped with a paracentesis, and several liters of acidic fluid were removed. A few minutes later, the patient's blood pressure absolutely tanks. What happened? When you pull all that fluid out of the abdomen quickly, fluid from the bloodstream rushes to fill that empty space, causing sudden hypovolemic shock. Your first action is to lay the patient flat to help blood flow to the brain. Crank up the IV fluids and notify the provider. Okay, time for a rapid-fire review. Let's connect the dots. If you see raw oysters in a question, you think hepatitis A. If you see a flapping hand tremor, you think asterixis from high ammonia. If you see any cirrhosis patient suddenly become confused, you think high ammonia. And if a question asks about the goal of lactulose, it's not just about bowel movements, it's about an improved mental status.
Let's end with a classic NCLEX-style priority question. You've got a patient with cirrhosis and a history of alcohol abuse who is suddenly agitated and confused. What is your very first top priority assessment? Now, you might be thinking about alcohol withdrawal, and that's a fair thought. But the most immediate, life-threatening problem here is hepatic encephalopathy. Your priority is to assess for asterixis to see if dangerously high ammonia is the cause. Remember, on the NCLEX, always rule out the most acute physiological problem first. Thanks for joining me.
All right, future nurses, welcome. So here's our game plan for today. We're going to kick things off with nausea and vomiting, then jump right into diarrhea and the dreaded C. diff. After that, it's all about H. pylori and peptic ulcers. Then we'll tackle constipation, and we'll wrap it all up with hemorrhoids. Let's get into it. First up, nausea and vomiting. You are going to see this all the time. But remember, these aren't just symptoms, they're clues. And your ability to assess what's going on, understand why, and act quickly, well, that's what makes you a great nurse. Let's start with the absolute basics. What is nausea? We've all felt it, right? That awful, queasy feeling deep in your stomach that just tells you something is off. Think of it as the body's first alarm bell. It's a huge clue that could point to almost anything, from pregnancy to a GI bug to a reaction from a cancer treatment. Okay, pay close attention to this slide because this is pure NCLEX gold. The exam loves to test you on what a nurse can do before reaching for meds. These are your first-line actions, so you'll want to advise smaller, more frequent meals. And here's a big one. Drink liquids between meals, not with them. Why? Because that helps prevent the stomach from getting too full and distended. Room temp or chilled foods are usually a lot easier to tolerate, and simple carbs like crackers or toast, they can work wonders. And don't forget the power of smell. Just avoiding strong odors can make a world of difference. So, what happens when things get worse? The nausea is just too much, and your patient actually starts vomiting. What's your game plan now? What becomes the priority?
The key here is simple, slow and steady. You absolutely cannot rush the gut. You have to let the stomach rest and then reintroduce things very, very gently. And this progression you see here, it is non-negotiable. First, the patient is NPO, nothing by mouth, period. Once the vomiting has completely stopped, you can start with small sips of clear liquids. If, and only if, those stay down, you can advance to full liquids. And then finally, you can slowly and carefully bring back solid foods.
And this brings us to our #1 concern with vomiting, dehydration. It's the biggest risk. Every bit of fluid that comes out is a loss that the body has to compensate for. So your top priority is to be a hydration detective. You're going to monitor their intake and output super closely, you're going to check their skin turgor, and you're going to watch their vital signs like a hawk. And you really have to remember that kids and the elderly can get dangerously dehydrated incredibly fast.
All right, let's move on to our next section, which really builds on that last point. We're talking about diarrhea and C. difficile. And just like with vomiting, the immediate enemy isn't what you might think it is.
Let this one really sink in, because it's a fundamental nursing concept. When you have a patient with diarrhea, your biggest concern isn't stopping the diarrhea itself. It's managing the massive loss of fluids and electrolytes. Your assessment always starts with their hydration status. And to do that assessment right, you need to have these signs memorized. Tachycardia, a fast heart rate. That's the body's first attempt to compensate for low fluid. As things get worse, their blood pressure will drop, hypotension. You'll see dry mucous membranes, their urine output will decrease, and you'll see poor skin turgor. A weak, thready pulse, that is a very late and very, very bad sign.
Okay, time for a classic NCLEX scenario. Your patient just finished a course of antibiotics. Now, all of a sudden, they have this really foul-smelling, watery diarrhea. What alarm bells are going off in your head right now? You should be thinking C. diff immediately. The huge giveaway is the recent antibiotic use. See, broad-spectrum antibiotics, they don't just kill the bad bacteria, they can wipe out all the good protective bacteria in our gut too. And that creates the perfect opportunity for C. diff to move in, take over, and cause a nasty inflammation of the colon. Now, if you even suspect C. diff, your very first move is infection control. That means putting the patient on contact precautions. And here is an absolute must-know critical safety point that you will be tested on. Alcohol-based hand sanitizer does not kill C. diff spores. It doesn't work. You have to physically wash your hands with good old-fashioned soap and water to get rid of them.
Okay, let's switch gears a little bit. We've talked about fluid balance. Now let's talk about the actual lining of the GI tract. We're moving on to H. pylori and peptic ulcers, where the stomach's own protective barrier is under attack.
So, peptic ulcer disease, or PUD, is basically a sore. It's an open wound in that protective mucosal lining of the stomach or the first part of the small intestine. And for the NCLEX, you have to know the two main culprits that cause it: an infection from a bacteria called H. pylori and the chronic use of NSAIDs, think ibuprofen or naproxen.
Because of that, a huge part of your job as the nurse revolves around patient teaching. You have to teach them how to protect that damaged lining so it can heal. That means no more NSAIDs. It means cutting back on alcohol and caffeine, which can really irritate the stomach. And it's so important that they stop smoking, because smoking messes with blood flow and seriously slows down the healing process.
Now, listen very closely. This is a red flag you can never miss. If your patient with PUD tells you they're vomiting something that looks like coffee grounds, or if they're passing black, tarry stools, that's called melena, you need to act immediately. These are the classic signs that their ulcer has eroded into a blood vessel. This is an active upper GI bleed, and it is a medical emergency.
Okay, let's pivot to something you'll see all the time in your nursing career. It might seem like a simple problem, but managing it well is so important for your patient's comforts and for preventing other complications. Let's talk about constipation. You know, what's great about this slide is just how simple and logical it is. The solutions for constipation are the direct opposite of the causes. The patient's not drinking enough fluids? The answer is to increase fluid intake. Not eating enough fiber? Add more high-fiber foods. Not moving around enough? Well, we need to increase their physical activity. Your first move is always going to be these lifestyle changes.
And that leads us perfectly into our final topic for today, hemorrhoids. Because a lot of the time, this painful condition is a direct result of the chronic straining that comes along with constipation.
Just look at the common causes here. You've got constipation and straining, pregnancy, obesity, even things like heavy weightlifting. What do they all have in common? They all increase the pressure down in the lower rectum. And it's that pressure that causes the veins to swell and bulge out, which is what a hemorrhoid is. When your patient describes their symptoms, this is the classic phrase you need to listen for: painless, bright red bleeding on the toilet paper. The key here is that the blood is bright red. That tells you it's fresh blood from a source that's very close to the exit, a huge clue that points right to hemorrhoids.
And this slide really brings everything full circle. Just look at the key patient teaching points after someone has surgery for hemorrhoids. Does it look familiar? It absolutely should. It's the exact same advice we give for managing constipation in the first place. The goal isn't just to heal from the surgery, it's to break that whole cycle so it doesn't happen again.
So, let's end with this final thought. In the real world, your patients won't have just one neat little problem. They'll come in with multiple GI symptoms. So how do you prioritize? What's the biggest threat right now? Is it dehydration? Is it bleeding? Is it an infection? Being able to answer that question, well, that is the heart of great nursing judgment.
We're going to make sure you can spot those red flags every single time. So let me just ask you this straight up. Why would something as common as a little nausea or a bit of diarrhea be the reason someone could fail their boards? It sounds kind of crazy, right? What's the hidden danger they're testing for? And here's the answer. It's because the NCLEX is all about safety. They don't just want to know if you can hand out a pill. They want to know if you can see the disaster that might be brewing underneath. It's all about recognizing when a simple complaint is actually the tip of a very, very dangerous iceberg. Okay, so here's our game plan for today. We're going to hit the big alarms for nausea and vomiting. We'll get into the dangerous world of diarrhea and C. diff. Then we'll tackle H. pylori's triple threat, constipation complications, and hemorrhoid care. And we'll wrap it all up with a rapid-fire review to make sure it sticks. First up, nausea and vomiting. This is a classic NCLEX topic because it really tests your judgment. Can you tell a difference between some expected post-op queasiness and the warning signs of something catastrophic, like a bowel perforation? Let's find out. All right, let's talk about 3 antiemetics you absolutely have to know. First, ondansetron. When you see this drug, your brain should immediately think heart. You've got to watch that EKG for QT prolongation. Next, metoclopramide. The big, scary buzzword here is extrapyramidal symptoms, or EPS. And finally, promethazine. This one is a huge safety issue. It can make patients incredibly drowsy, so your #1 teaching point is absolutely no driving. So what in the world are extrapyramidal symptoms? Well, think of it like the brain's signals to the muscles are getting all scrambled. You might see muscle rigidity, tremors, or that really distinctive tardive dyskinesia. You know, the involuntary lip smacking, blinking, or twitching. This is no joke. It's so serious that Medical Primide actually has a black box warning for it. So, here is your critical, high-priority nursing action. If you're giving metoclopramide and you see any of those signs, especially facial twitching, what do you do first? You stop the infusion. You stop the med. That's always the first step. Then you call the provider. That order is key. And here it is, the ultimate red flag for vomiting. If your patient just cannot stop vomiting and their abdomen is hard, like board-like and rigid, you have to think obstruction or perforation. This isn't a let's wait and see moment. This is a drop everything, call the surgeon, surgical emergency. Okay, let's move on to diarrhea. Now, this one is tricky because your first instinct is to just stop it, right? But the NCLEX wants to know if you understand that sometimes stopping it is the absolute worst thing you can do. The body is trying to get rid of something bad, and you don't want to trap it inside. Listen up, because giving a drug like loperamide is a classic NCLEX safety trap. It's totally fine for run-of-the-mill, non-infectious diarrhea. But if you see any sign of infection, we're talking high fever, bloody stool, or if you even suspect C. diff, you absolutely do not give it. Why? Because you could literally trap that nasty bacteria inside the gut, potentially leading to toxic megacolon. And trust me, that is as bad as it sounds. And speaking of C. diff, there are some non-negotiable rules here. First, that patient goes on contact precautions immediately. And this is a huge one for exams. Alcohol-based hand sanitizer does not kill C. diff spores. You have to physically wash them away with soap and water. And of course, use dedicated equipment for that patient and keep a very close eye on their white count and their temperature. Here is another favorite NCLEX gotcha question. They'll say your patient has C. diff, and one of the options will be IV vancomycin. It's a trap. The infection is in the gut. IV vancomycin stays in the bloodstream. It never gets to where the infection is. To kill C. diff, you have to give the vancomycin orally, so it can travel through the gut and fight the bacteria directly. Route matters. Next up, we have H. pylori. The NCLEX loves this because it's the perfect storm of microbiology, pharmacology, and emergency assessment. I want you to think of it as a triple threat. You've got the bacteria itself, the painful ulcer it causes, and the potential for a catastrophic emergency. So, how do we fight this triple threat? With something called, wait for it, triple therapy. It's actually pretty straightforward. It's a cocktail of 2 different antibiotics to kill the bacteria, plus a proton pump inhibitor, or a PPI, to cut down on stomach acid and give that ulcer a chance to heal. Now, giving the meds is just part of the job. The patient teaching here is absolutely critical. You have to stress that they must finish the entire course of antibiotics, even if they start feeling better. If they stop early, the bug can come back stronger. And that PPI, it has to be taken before meals to work right, not just when the pain kicks in. All right, let's talk about constipation. And you're probably sensing a pattern by now, right? The NCLEX takes a common problem that we see all the time, and they want to know if you can spot the rare but deadly complication hiding in the background. In this case, that's a full-blown bowel obstruction. So let's do a quick flyby of the different types of laxatives. You've got your bulk-forming agents like psyllium. That's basically fiber, and you have to take it with a ton of water, or you're just making cement. Stool softeners just make things easier to pass. They don't actually make you go. Osmotics pull water into the bowel. And then you have the stimulants, like senna. These are the big guns, and you have to be careful with them because patients can become dependent. And here is the single most important takeaway for constipation. If a patient suddenly becomes constipated, but they also have abdominal pain, a hard bloated belly, and they're vomiting, you have to suspect a bowel obstruction. Giving a laxative in this situation is a disaster. It's like trying to push more cars into a massive traffic jam. You're just going to cause a crash. Okay, and next up, a quick look at hemorrhoids. Now, for the NCLEX, the focus isn't so much on the hemorrhoids themselves, it's all about your priorities for post-operative care after a patient has a hemorrhoidectomy. So, here's the post-op game plan. For the first day, it's all about cold packs to keep that swelling down. After 24 hours, you can switch to warm sitz baths for comfort. But what's the absolute #1 top priority goal? It's preventing constipation. Any straining could pop those sutures and cause a major bleed. So, high-fiber foods and lots of fluids are your best friends here. All right, you've taken in a ton of information. Let's do a super fast rapid-fire review to lock these key facts into your brain. These are the things that show up over and over again on the exam. Ready? Loperamide, only for non-infectious diarrhea. No fever, no blood, period. C. diff treatment? It's oral vancomycin, not IV. Metoclopramide? Your eyes are peeled for EPS and facial twitching. Those PPIs for H. pylori? You gotta give them before meals for them to work. And finally, stimulant laxatives, they're for short-term use only. Don't let your patient get dependent on them. So, I'll leave you with this question. After going through all of this, which one of these so-called minor GI symptoms are you never ever going to look at the same way again? Answering that for yourself and really internalizing it, that's how you build the kind of clinical judgment you need to pass the NCLEX. You've got this. Post-op GI complications. They're a huge deal on the NCLEX. But here's the secret. It's not just about memorizing facts. It's about spotting the red flags and knowing what to do first. So today, we're going to cut through all the noise and focus on the priority nursing actions you'll actually use both for the test and on the floor. So, picture this. You're on your shift, and the call light goes off. It's your post-op gastrectomy patient. They just ate their first meal, and now they're dizzy, sweating, and feel super weak. What's your first move? Is it their heart? An allergic reaction? This is exactly the kind of clinical puzzle the NCLEX loves to throw at you, and we're about to break down exactly how to solve it. Here's our game plan. We're going to walk through 3 classic patient scenarios. First, dumping syndrome, then T-tube care after gallbladder surgery, and finally, assessing a brand new ostomy. After that, we'll wrap it all up with a rapid-fire roundup of the biggest red flags you just can't miss. All right, first up is our gastrectomy patient. Let's get to the bottom of why they're suddenly feeling so awful after that first meal. It's time to decode dumping syndrome. So what is actually happening inside their body? Well, after stomach surgery, the stomach's normal gatekeeping function is gone. So when a big, sugary load of food gets dumped into the small intestine way too fast, the body kind of freaks out. It yanks a ton of fluid from the bloodstream into the gut to try and dilute it all. And that massive sudden fluid shift is what causes all those dramatic symptoms. Now, this is where it gets really important for the NCLEX. There are 2 types, early and late. Early dumping happens within about 30 minutes, and it's caused by that big fluid shift we just talked about. But late dumping, that happens 1 to 3 hours later, and it's a completely different problem. That initial sugar rush causes a massive insulin spike, which then tanks the blood sugar, causing rebound hypoglycemia. See the difference? And that leads us right into a classic NCLEX trap. You have to know the difference because the way you treat them is totally different. For those early vasomotor symptoms, you want to slow everything down. But for the late hypoglycemic symptoms, you actually need to get their sugar up. Mixing these 2 up is a major mistake, so really lock this in. So the best cure here is prevention, and that all comes down to your teaching. You're going to tell your patient small, frequent meals, go easy on the sugar and carbs, and add more protein and fat to slow digestion. Now here's a huge one. Drink fluids between meals, not with them. Drinking with food just turns their gut into a water slide. And a final trick? Have them lie down for about 30 minutes after eating. We're literally using gravity to put the brakes on. All right, let's move on to our next patient. You're now caring for someone who just had their gallbladder out, and they have a T-tube. Let's run through the must-know assessments for this little guy. T-tube care is all about making sure it drains properly and preventing any trouble. First things first, gravity is your best friend. That bag has to be positioned below the level of the gallbladder, always. You've got to be constantly checking for kinks in the tubing. And remember, bile is super harsh on the skin, so you need to keep that insertion site clean and dry. But most importantly,
You never, ever clamp that tube unless you have a specific doctor's order. That's a huge safety risk. You've got to know what's normal to spot what's not, right? So right after surgery, it's normal to see some bloody tinged drainage. But within a few days, that should change to that classic greenish-brown bile color. If it doesn't, that's a clue that something might be wrong.
Okay, here's a number you absolutely need to remember. More than 500 milliliters of drainage in 24 hours is a major red flag. This is way too much, and it could mean there's a serious issue like a hemorrhage. This is not a wait-and-see situation. You need to call the provider right away. So what happens if the tube gets blocked? Well, that bile has to go somewhere, and it starts backing up into the liver and into the bloodstream. Think about it logically. First, you'll see a sudden drop in the drainage output. Your patient's going to feel sick, nauseous, with pain right where their gallbladder used to be. Then you'll start to see those classic signs of obstruction: yellow skin or jaundice, a fever, and those telltale clay-colored stools. Okay, on to our third and final patient. This person has a brand new ostomy, and your assessment skills here are absolutely critical in the post-op period. This comparison is everything. You have to know what you're looking for. A healthy stoma should be nice and beefy red, moist, and a little shiny. That tells you it's got great blood flow. On the flip side, if you see a stoma that looks pale, gray, dusky, or even purple, that is a surgical emergency. It's screaming that it's not getting enough blood and that tissue is dying. And this really drives the point home. These words, pale, gray, dusky, they are NCLEX code words for a circulation problem. If you see those words describing a stoma in a question, that's your priority. You have to report that to the healthcare provider immediately. Now, it's important to remember that not all ostomies are the same. An ileostomy bypasses the entire large intestine, and the large intestine is where we absorb most of our water. So the output is going to be very loose, watery, and high volume. This puts these patients at a huge risk for dehydration and losing electrolytes. It's a major safety issue you have to be on top of. And this chart gives you a really quick visual. Just think about the anatomy. Ileostomy output is liquidy and kind of greenish yellow because it hasn't had any water absorbed yet. A colostomy, which is further down the line, will have more formed brown output, a lot closer to a normal stool. Okay, let's do a rapid fire on your priority interventions. Number 1, empty that pouch when it's about a third full to prevent leaks. 2, when you cut the skin barrier, make it no more than 1/8 of an inch larger than the stoma itself. This protects the skin. 3, push those fluids up to 3 liters a day, especially for your ileostomy patients. And 4, start them on a low-fiber diet for the first few weeks to prevent a blockage while things heal. All right, we have covered a ton of ground, so let's bring it all home and do a quick roundup of the absolute, no questions asked, when to call the provider situations. So let's boil it all down. For dumping syndrome, a severe hypoglycemic event where they're confused or unresponsive is a 911 situation. For the T-tube, call if the output is over 500 ml or if it suddenly stops and they spike a fever. For the ostomy, any of those dusky pale colors mean you pick up the phone. And a universal red flag for any post-op GI patient, a hard, rigid, board-like abdomen, that screams peritonitis and it's an emergency. Okay, let's end with one last classic prioritization question. Who are you running to see first? The late dumping patient needs some sugar. The T2 patient with 600 milliliters of drainage definitely needs to be addressed. But that patient with the dusky stoma, that is a circulation problem. Tissue is actively dying. Remember your ABCs: airway, breathing, circulation. The circulation issue trumps the others. That's always your priority. If you keep that framework in mind, you'll be golden.